I'm Mary Barton. I'm Vice President for Performance Measurement at the National Committee for Quality Assurance. I'm here to tell you a little bit about what our organization is and how it works. And to do that, I'm going to explain a little bit about performance measures. So when we think about how value-based healthcare should work, we should be able to maintain people's health. So people who are already at low risk, keep them at low risk. And for folks who are exhibiting signs and symptoms of disease or who have chronic illnesses, that we could maintain their health, prevent them from getting worse. And so this idea is really in contrast to the sort of last century of American medicine, where we paid people fee for service, paid them the more they did. Here's an idea that says maybe we could pay people for value basis. We could pay them for getting people better. And performance measures are really an important part of this goal. Next, I'm going to tell you a little bit about the HEDIS measure set, which is what NCQA uses to determine the quality of healthcare that is provided by health plans, both Medicare Advantage plans and also commercial and Medicaid plans. So HEDIS stands for the Healthcare Effectiveness Data and Information Set. This measurement set is used by more than 90% of American health plans. It permits a comparison of health plans to each other across important dimensions of care. So we have measures that look to see if patients or members received preventive services, whether they had managed their chronic conditions managed. We have several measures that address behavioral health services. In addition, we have measures that look at coordination of care and then overuse or appropriateness of care. There is without a doubt, in the last 20 years, we've seen a positive trend towards accountable healthcare systems. So this shows the millions of members in health plans that report HEDIS data and audited HEDIS data. So that means that the plan's numbers are checked. And so, you know, back in the year 2000, there were maybe 50 million members in such plans. Now we have 191 million Americans in health plans that report HEDIS data. The most recent set of HEDIS measures include 92 measures across 6 domains. These are reported by all health plans that have that are accredited by NCQA, or health plans that have state requirements to report, or for example, all Medicare Advantage plans are required to report the HEDIS measures to NCQA. So when you think about the domains, we have here listed the effectiveness of care domain. That is really all of the things that have to do with high quality medical care. We have 5 measures in the access and availability of care domain. There are 3 measures that comes from the CAP survey about the experience of care. And then we have measures in the utilization, risk-adjusted utilization, and health plan descriptive information sets. And finally, measures collected using electronic clinical data systems. These are measures that take advantage of clinical data, whether it comes from EHRs or registries, and puts that together with information from other electronic sources such as claims data or health plan administrative data in order to report on quality at I would say, a finer layer of, a more finely detailed layer of quality than we could do with just claims data alone. Now, where are these HEDIS measures used? In addition to NCQA using these measures in our own accreditation programs, they're used by the Center for Medicare and Medicaid Services, CMS, has 10 measures of ours in their ACO program, 33 measures of ours in their quality payment program, which is the individual clinician program, 24 in their quality rating system, which they're going to be using to compare the marketplace plans to one another. 14 measures in CMS Part C star ratings, 10 in the Part C display, 17 measures in the Medicaid adult core set, and 12 in the Medicaid child core set. So HEDIS measures are widely used and really looked to determine quality of care. When we look at the 55 measures in the effectiveness of care set, here you can see a distribution of the sort of health categories that they're in. We have a lot of measures in the prevention and screening set, and then also respiratory, cardiovascular care, diabetes, behavioral health I mentioned before, overuse and appropriateness. All of these categories include measures that aim to distinguish one health plan from another. I'm going to talk now a little bit about how we develop measures, because I think this is important to what this panel is going to be discussing. Whenever we create a measure, we're looking to make sure that it meets all of our desirable attributes, and that includes relevance, both to stakeholders, to potentially to patients, possibly to the financial impact of improvement. And also this implies that there needs to be substantial variation in care, because it wouldn't benefit you to measure something if everybody was already performing at 100%, right? Scientific soundness, very important. This is making sure that our measures are based on the best evidence and the strongest guidelines, because we don't want to be encouraging care unless we feel confident that this is going to benefit the patients that are receiving that care. Processes are sometimes measured, or structural measures sometimes, but we look to make sure that those are linked to outcomes. So for example, there's lots of evidence about breast cancer screening. We have a measure that says, did patients get breast cancer screening? That's a process measure that looks that a process was done, but it's strongly linked to outcomes based on extensive research literature. We also, in the scientific soundness category, look to make sure that the data that is used to report the measure is reliable and accurate, and therefore the measure is valid. And then finally, feasibility is an important issue, because we need to make sure that the measure is specified as precisely as it can be, that needed data is available to supply that measure, and that the cost of data collection is reasonable. Finally, I mentioned audited data, and CQA has an audit protocol that it uses to audit all health plans that report HEDIS data to us. And that audit is really a key part of what we mean when we say we have a performance measure. And so the ability to be audited is an important part of the feasibility of a performance measure. So I'm going to talk a teeny bit more now about data sources and data collection methods, because there is an evolving data landscape that we're in the midst of. The box above shows what traditionally HEDIS has used: administrative data, sometimes hybrid, what we call the hybrid method, which is when administrative data is used for part of the measure, but then a sample of medical records is pulled for the other part of the measure. And then finally, the survey method. I mentioned CAPS. We also have used in the past the Medicare Health Outcomes Survey to collect a health plan measure. I want to mention, though, on the right side of the box is what is called supplemental data. So when health plans have been reporting an administrative measure, they may have been including laboratory results or data from registries or other kinds of supplemental data to support the reporting of their measures. Our newest entry in the category of data collection methods is the electronic clinical data systems method. The reason that we designed this was that we knew that there were ways to use data that was standardized. The supplemental data has been kind of a thorn in the side of both health plans and auditors because of the difficulty in auditing it. And we knew that if we could line up the way that data comes into the health plan from registries or case management systems or claims, that they could bring that data together and report it in a standardized way. And so that is what the electronic clinical data systems method is it's a way for health plans to report digital quality measures that are expressed digitally and that are gathered digitally. And so that is really something that I can't give you enough detail about. If you want more, you can go to www.ncqa.org/ECDS to get all the information you might possibly want about this approach. The data collection methods are interesting in that they differ by both the denominator and then also the pros and cons of that method. So the denominator for administrative measures is typically the entire eligible population. The pros of this kind of measurement is that it's less expensive and less time consuming. However, a con is that it lacks clinical detail. Typically, there's really ability to understand anything else about the clinical situation that the patients are in. Hybrid measurement uses a systematic sample, and so that is has the potential to be more accurate as a way of describing healthcare provided to patients, but it's extremely resource intensive. So sending out these reviewers to do charts is really quite expensive. The survey measures use also a random sample, and it is a to capture a patient perspective because you're asking the patient themselves to, speak for themselves. But it is also expensive, and I will say that they feel that survey data is less actionable because you don't know who is the patient who had the bad experience. You have no way to intervene on a person level with them. Finally, the ECDS approach is a way then to use the entire population, the entire eligible population, and to capture clinical data that is efficient, an efficient approach and is more actionable. However, health plan capabilities vary in their ability to get access to this clinical data. And so right now we are in the situation where most of our 11 ECDS measures are voluntary in terms of reporting. However, we have our first publicly reported ECDS measure in HEDIS now, which is a prenatal vaccination measure. Now, not all great ideas make great measures. We have situations where you might know that something is clinically important, but it might lack specific evidence. It might be an area where science is changing rapidly. And in some cases, there is a good argument to be made that risk adjustment would be important to the performance of a performance measure in this space, and that it would be appropriate to do, but it might be very hard to do or impossible to do. There are several technical problems that come around with measurement. If there are small numbers or small numbers of cases or small numbers of events, then it's very hard to get a reliable measurement that compares one entity to another. Data sources are also potentially a problem. because you might have different capacities to access different kinds of data among different health plans, and therefore you wouldn't be able to have a fair comparison across them. And then there are sometimes external issues. Users, and that includes clinicians and health plans and patients potentially, should be able to understand the results and understand the link to quality. Sometimes there are health plans have actually limited capacity to control or influence certain kinds of outcomes. So those measures aren't seen really as being fair. And then finally, other differences in delivery systems in regions of the country or in populations might also make it difficult to make a fair measure. And so therefore, really impossible to make a great measure. The HEDIS measure development process goes through a set of repeatable steps, and I'm going to just say a word about each of them, but it goes in this cycle. And so if we look at selection, that means that we pick the topic area, and we almost always conduct an environmental scan, review guidelines, review available evidence, and consult stakeholders. We then prioritize these concepts because we can't do, our eyes are bigger than our stomach. We can't do all of the things that we want to do. When we do measure development, this is an iterative process that includes repeated asks of stakeholders of their opinions. So we have assessment of feasibility, we evaluate importance to make sure that there's a gap in quality, we draft specifications, so that's really the outline of the measure components, the denominator, the numerator, exclusions, and then we do testing to assess the scientific soundness of our idea. We have an important bolus of stakeholder input when we do public comment. So public comment is undertaken for every single new measure and almost all of our reevaluated measures. Our annual public comment period is held in February to March. We happen to be doing an additional public comment period right now, so in October of this fall. And the stakeholders that look at our public comment include health plans, clinicians, specialty groups, consumer groups, policymakers, and advocacy groups. We get feedback that runs the gamut from relevance and importance to feasibility and burden. We sometimes get a detailed comment about a technical specification, and many times we get global measure development comments. First year analysis. First year is important because we don't publicly report measures in their first year of existence. We review measures to make sure that they're working as we planned, that it's feasible to report the data, and that there appears to be a variation in performance. After that first year status, measures that succeed well on all of those counts can be voted forward to public reporting. And public reporting is used, stakeholders are told during the October technical update which measures will be publicly reported. And then the following summer, the results are made available on NCQA's Quality Compass and incorporated into NCQA's health plan ratings. Evaluation is important because our measures are periodically looked at for updates. As you can imagine, evidence changes, and so measures need to change as well. We review updates to guidelines or changes within the healthcare delivery system. Sometimes there are new interventions or new codes that need to be added. We review feedback that comes in through our policy clarification support system. So this is what health plans who are reporting HEDIS measures use to ask questions of us about specifications or details about what counts. They put those queries into the policy clarification support system. And that is a great source of us to get feedback. It's a constant feedback loop for us in our measure development. We also solicit feedback from our our specialty panels, our public stakeholders, federal partners, and other users of our measures. And we look at all the historic performance results from our measures. So ongoing maintenance means that even when we're not reevaluating a measure overtly, we have this low-level constant updating that goes on where codes are reviewed, drug codes, NDC codes. We have special NCQA panels that look at those codes. We update the models that are used for risk adjustment. So we use CMS's HCCs and CCs for risk adjustment. And so whenever those are updated, we have to update our models as well. And we review the feedback and comments from the field. As I mentioned, the Policy Clarification Support System, as well as other entities such as the HEDIS users group. Now, not all measures are destined to live forever. Sometimes there's a good reason to retire measures. If the quality gap has closed and everybody's doing great, then that might be a reason to retire a measure. There might be better measures available. We may have been able to raise the bar in terms of quality, and then we can retire the lower bar measures. So when we put our measures into health plan accreditation, as I mentioned, we also use measures to compare plans to one another. And we have other programs that we use to ascertain that health care is being provided in an excellent way. We have a diabetes recognition program. We have a patient-centered medical home recognition program, patient specialty practice recognition. All of these exemplify our commitment to measurement, transparency, and accountability. And with that, I think I'd be happy to answer any questions that folks have.